Hi, everybody. I'm happy to welcome you to this AXSANA Initiation video conference. My name is Thorsten Kühn, and I'm the chairman of the European Breast Cancer Research Association of Surgical Trialists and PI of the AXSANA study. And I'm very happy that so many people joined this video conference today. As you know, the AXSANA is an acronym for axillary surgery after neoadjuvant treatment. And it's a prospective multicenter cohort study to evaluate different surgical methods of axillary staging in clinical node positive breast cancer patients treated with neoadjuvant chemotherapy. So the sponsor of the study is UBreast. The AXSANA study is a low budget study, so we do not have large funds from industry or from pharmaceutical companies. So we have donations from scientific organizations like the AGOB, the AWO GUN, the Claudia von Schilling Foundation. We are supported by Karolinska Institute, NOGO, GBG, and we have some donations from Endomac and Mammotome. So we have the International Steering Board consisting of the chairs. We have our national protocol team, and we also have an international steering board consisting of one representative of every participating countries. Next slide, please. So the background or rationale, the optimal staging, surgical staging, as you all know, of the axilla in patients who convert from clinical node negative to clinical node, from positive to clinical node negative through neoadjuvant chemotherapy is unclear. So for many decades, we performed axial lymph node dissection, but due to the high morbidity of the procedure, the axial lymph node dissection was challenged by less invasive techniques like the central lymph node biopsy. And as you know, the central lymph node biopsy is associated with the false negative rate that is judged to be too high for axillary staging. So new methods like the target lymph node biopsy or target axillary section were introduced. But so far, we only have data on detection of false negative rates, and we have no comparative data on the oncological outcome or the morbidity of different procedures. And this leads to the fact that recommendations vary widely in different countries. So the AXSANA study is a European prospective cohort study, and the target accrual is 3,000 patients, and so far 20 countries are participating. And the interesting thing of the AXSANA study is that we have many different recommendations in many different countries, and this allows us to conduct this registry study in order to compare the different techniques with regard to oncologic endpoints and life quality. So it is important that study participation does not influence the choice of therapy.
Thorsten, du bist kurz stumm.
I don't know how this happened. Okay. When was I muted? Should I?
2 seconds ago.
2 seconds. I hear a funny noise. Is it better now?
Yes, it was someone's echo. I'm trying to mute everyone.
Okay, perfect. So I very shortly repeat, it's a European prospective cohort study with a target accrual of 3,000 patients. And so far we have 20 countries. And I'm very happy that we have many participating countries, not the core of Europe, but we have India participating, Russia with very active breast surgeons, also Turkey. So it's a very large community that is interested to participate in our study. So as I said, the study participation does not influence the choice of therapy. So there's no experimental arm in the study, and diagnostics and therapy are conducted according to national and institutional standards. Next slide, please. So what are the study aims? As I already said, we have 3 primary study aims. The first one is invasive disease-free survival in patients who convert from node positive to node negative. And we want to compare the different staging techniques axial lymph node dissection, targeted axial lymph node dissection, central lymph node biopsy, and targeted lymph node biopsy. So it's not a study that only focuses on one technique like the targeted axial resection. We want every patient with every technique performed in the study. The second primary endpoint is axial recurrence rate. And certainly we want to look at life quality and compare the different staging techniques with regard to life quality. Next slide, please. There are many secondary study aims. Certainly the feasibility of different forms of axial staging procedures, the detection rates of target axial resection, central lymph node biopsy, or target lymph node biopsy, the number of removed nodes associated with each technique as surrogate parameter for surgical extent, the operating time as a surrogate parameter for surgical resources. We want to assess factors that are associated with the successful detection of the target lymph node. So, as you know, there are many different marking procedures. We want to analyze the impact of experience on the success rates for target lymph node, target axial resection. And we also will have an arm where patients convert to clinical node negative, but they have a positive histologic status, a YPN plus status. And we want to compare different therapeutic options like axial lymph node dissection versus radiation therapy. And you may know that there were many controversial discussions on this issue at the St. Gallen conference this year. So we want to analyze factors contribute to life quality, which is an important part of the study, and certainly economic resources, and that is why we assess the time of surgery in the study. Now to the flow chart of the study. What are the inclusion criteria? Patients should have a primary invasive breast cancer, CT1 to CT4C, should be clinical node positive, should be scheduled for neoadjuvant chemotherapy, and we include female as well as male patients. So the patient presents with a clinical node positive status. Next slide, Steffi. And we suggest to perform a fine needle aspiration or core needle biopsy on the patient. However, we had an amendment to the protocol recently that we also allow patients with highly suspicious nodes on imaging to be included into the study. We had this amendment because we had a lot of discussion on this point, and we saw that in many countries, a regular or routine core biopsy for positive lymph nodes was not a standard of care. And in order not to lose these patients, and because it's a clinical reality, we allow these patients to be included in the study. Now, we always will have patients who have, next slide, who will have negative core needle biopsy, but there is a negative imaging pathologic correlation. So it's not the result of inconclusive. In this case, we suggest to go back and have another ultrasound, discuss the situation, and if you're clearly convinced that the patient is not positive, and we all know these cases, the patient can be included. The standard should be, and we really would encourage you to do a FNA or core needle biopsy wherever you can. So once the diagnostic of node positive patients who will undergo neoadjuvant chemotherapy is confirmed, you may mark the lymph node, but you must not mark the lymph node, because for those who go for axial lymph node dissection, they will not mark the lymph node. But for those who will go for target axial dissection, you will mark the lymph node with every technique that that you want to perform. The patient then registers to the study, undergoes neoadjuvant chemotherapy, and all the additional treatment, the adjuvant treatment regarding systemic treatment or radiation treatment will be performed according to national guidelines. For patients who still remain lymph node positive after neoadjuvant chemotherapy, we document the treatment that you choose, and this patient will, these documentation will be included into the CRF, but we will not have a follow-up for this patient. Exclusion criterion, certainly distant metastasis, recurrent inflammatory, bilateral, history of invasive breast cancer, supraclavicular or parasternal node metastasis, and axillary surgery before neoadjuvant chemotherapy or pregnancies, but these are very common criteria or exclusion criteria. Next slide. So this was my introduction to the study, and if there are any questions, you may just write into the chat, and otherwise we will continue with Dr. Hartmann from Rostock to give you some information on the documentation.
Thank you. During the next minutes, I would like to give you information about the documents that are sent to your study site by the National Steering Committee and by EUBreast, and also how you can register patients into the AXSANA trial. Each country has its own national steering committee, and this steering committee is coordinating all the study activities of the AXSANA trial for their country. And this national steering committee is sending important information and documents to your study site, usually via email. Your National Steering Committee distributes the site IDs for this single study sites, and it's also sending the documents that are shown here. This will be a current study protocol and patient information and informed consent form, and you will get a signature and delegation log and a subject ID log, and also PDF files of the study's CRF and quality of life questionnaires. The patient registry and documentation within the AXSANA trial is only possible via an eCRF documentation system. And the access data and also a user manual for this documentation system will be sent to your study site directly by EUBreast and not from your National Steering Committee. And once the online version of the quality of life questionnaires will be available for your country, then your study site will also get an email from our quality of life team in Sweden, including the access data and a user manual for the online quality of life system. As I already said, the national or your National Steering Committee is organizing all your local study organization, and the National Steering Committee has such an Excel file where all the study sites in their countries are listed. We kindly ask the National Steering Committee always to send this updated Excel file to EUBreast anytime a new study site is opened at their country. And in this list, you can see will be distributed the site IDs for the single study sites. At your study site, please set up your own investigator binder where all the documents regarding the AXSANA study should be stored. In this study binder, please also put the written informed consent forms of the patients that you include into the trial. And it is important that in this study binder should also be stored the subject ID log. I will show you this log later on. And if you would like to register a new patient for the AXSANA trial, you have to create an individual patient ID on this subject ID log. The patient ID has to be created as shown here. It consists of 3 parts, and the first 2 parts are identical to the site ID that is sent to you together with your documents from your National Steering Committee. The last part of the patient ID you have to create on your own at the study site. This will be an ongoing patient number, meaning that the first patient you include into the trial will be 001, the second 002, and so on. And after you created this patient ID, you can register the patient for the trial via the eCRF documentation system. Here you see one document that is sent to you from your National Steering Committee. This is the signature and delegation log. Before you can start recruiting patients, you have to fill this signature and delegation log and send it to your National Steering Committee via fax or email. On this first page, please list all the persons that are involved at your study site into the trial, give them a function, and everybody, also your local PI, has to sign here. Here you can see the second page of the signature and delegation log, and it is important that the second page should be filled electronically. Please send this second page also to your National Steering Committee. On this second page, you should write the names and email addresses of all the persons at your study site that should get access data for the eCRF registry and documentation system of the trial. Your National Steering Committee will send this list to UBREST, and you, all the persons that are listed here will get access data and a user manual for this eCRF system via email. Here you can see the subject ID log. I already talked about it. On this subject ID log, you can find your site ID on the upper right. And it is important that this subject ID log should be stored at your study binder, but you should not send it to your steering committee or to UBREST. It is only for your internal use and for your control which patient you included into the AXSANA trial. Meaning you should fill in here or register here the data of the patients that you include into the trial. And in this table, you should create the patient ID that you need for registry. The perfect time point for including patients into the AXSANA trial is before starting primary systemic therapy, because at this time point, usually all the data that you need for patient inclusion and registry are available. But we would like to encourage you to screen your patients that are already undergoing primary systemic therapy or perhaps did already finish it, because whether they fit or meet the inclusion criteria for the AXSANA trial. Because if all the data you need for inclusion are available, you can include patients until the day before surgery. After surgery, there's no more inclusion possible because the first quality of life questionnaire has to be completed by the patient within 4 weeks before surgery. If you want to register a new patient, you have to use the AXSANA eCRF documentation system, which is a REDCap database. Together with the other study documents, you will also get a PDF file of the study's CRF forms. And if you would like to, you can use these CRF version for your internal documentation, but it is not possible to register patients using this paper version. Patient registry and documentation for the AXSANA trial is only possible via the eCRF documentation system. Once you've opened this REDCap database, you can register new patients for the trial using the patient ID that you have created on the subject ID log. And you will see a table like this where all the patients that you already included into the trial at your study site are listed. And you can see the CRF forms for each single patient. If you see a red colored CRF, then it's a symbol for incomplete, meaning you did already start documentation within this CRF form at your study site, but you did not yet finish it. Once you finish the documentation within a CRF form, then you can change the status of this form on the bottom of each page to complete, and the color of the CRF form will change to green. Only if the data were inconclusive or incomplete found out by the monitor, then the monitor will change the status from complete to unverified, and the color of the CRF form will change to yellow. The monitoring procedure starts for all the green complete CRF forms, and if all data were found to be complete and conclusive, the monitor will log the CRF form, which is symbolized or shown by such a small log sign. It is important that you at the study site do never use this log function. This should only be used by the monitor. If you see a red colored CRF, please open this, not red, sorry, yellow colored CRF. Please reopen this CRF page and look for such a small yellow speech bubble. Clicking on this speech bubble, you will find a query that was created by the monitor. You can read this query, and you can check the data with, or you should check the data in the CRF form again, and you can change this. And afterwards, you should reply with a response and comment on the query and respond to this query. At this stage, it is important that the status of the CRF form should remain unverified until the monitor has checked the data and the response to the query again. Afterwards, the monitor will complete the status or the CRF form, and the monitor will log the CRF page. And now Ms. Barney-Palichowski will explain the single CRF pages of the trial. Thank you.
Thank you, Steffi. So as you have heard, we have already more than 400 patients that have been recruited to the AXSANA study, which means that we had already the opportunity to gather first experiences with our CRF and of course with the electronic version with the eCRF. So let me just guide you through the most important mistakes that are possible with our CRF. The CRF starts with baseline data, and these are data that you probably know from other clinical trials. So these are very basic details that we ask. Steffi, can you click me to the presentation? Then we ask you about the node status, and this is a quite detailed analysis and detailed questions that we will ask you. As you have heard from Professor Kuhn, it is not mandatory to perform minimally invasive biopsy since the amendment that we have had in January, but this is very important. You can click further, that in case you have not performed a biopsy, or in case you have performed a biopsy which has been inconclusive or negative, that you speak about the patient again, preferably in the tumor board, interdisciplinary, and then you declare the patient as CN+. So in this case, the participation in the AXSANA study is still possible. The marking of the target lymph node should be done according to your national and institutional standards, and this is not mandatory for all of you who perform sentinel node biopsy alone or axillary lymph node dissection. So this you should do as you do in the clinical routine. One question that can be misunderstood quite easily is this one. We ask you, in case you mark the lymph node, whether you already have confirmed that there is a lymph node metastasis. So there are some study sites that do place the marker, for example, a clip or a coil, directly after the biopsy in one procedure, which is quite nice for the patient because it's just one invasive procedure. But at this time point, they do not know if the pathological or cytological report will really confirm the lymph node metastasis. And there are other study sites that wait until they have received the pathological or cytological report. Right now, we don't really know which strategy is better, so you should just do what you already do in the clinical routine, but just keep in mind that you should answer this question with no if you place the marker immediately after the biopsy, because of course, in this setting, you don't really have the confirmation by the pathologist. If you use a marker to mark the target lymph node, it is very, very essential for us to know which marker you have chosen. In case of clips, for example, there are different manufacturers and different types. One example is, for example, the Hydromark marker that comes in 3 different shapes. So try to be as specific as possible. You can also choose to write the complete reference number of the clip you have used, and this will help us a lot during our analysis. The second part of CRF you should complete after neoadjuvant chemotherapy, but before the surgery. So this is the time point when your patients should respond to quality of life questionnaires. So this is why you have a small reminder for this, because the time slot to do this is quite short. The patients need to complete quality of life questionnaires between 4 weeks before surgery and the day of surgery. So don't forget it, because if the patients did not complete the baseline questionnaires, it is not possible to compare the follow-up data to the baseline. Here we also ask you which kind of axillary staging strategy you have chosen. And as you can see, there are several different options. Beginning with axillary lymph node dissection, followed by targeted axillary dissection or sentinel node biopsy alone. We have found that some study sites, for example, mark the target lymph node, but they do not perform a classical target axillary dissection, and they do not search specifically for this target lymph node. They perform sentinel node biopsy, and they send the sentinel lymph node to their radiologist to see if the clip is inside or not. And as we know from previous studies, in 75% of patients, the clip will be inside the sentinel node. So this is why we have included this option. And if you think that the option that you are following, the strategy that you have chosen, is not here, please just choose other and write in the free text and try to be as specific as possible. Some of you are probably using magnetic seeds or radio frequency seeds or radar markers, and these markers are at least assumed to cause some kind of MRI artifact. So this is why we have built in the question about the artifacts, because we would like to know, well, first, if there are any artifacts, and second, if they are clinically relevant when performing MRI. Then comes the CRF part that you will be completing after the surgery. And in my experience, it's easiest to do this immediately after the surgery. So it might be quite useful to print out the CRF, even if you have to transfer all the data to the eCRF later. So here we ask you, for example, how long the surgery took. And we really want to know the whole time for the whole surgery. So we do not expect you to measure something that you would not have measured outside of the study. You should just give us a time between the incision of the skin and the closure of the skin of the whole procedure. And of course, we know that some of you do perform reconstructive surgery or maybe you have operated on the other breast at the same procedure, or maybe you have performed any kind of flap reconstruction, for example, which makes the surgery time, of course, longer. And from the analysis of the surgery duration, we will, of course, exclude these patients. So this is why we ask you in the following questions whether you have performed contralateral surgery or any kind of reconstructive surgery. And here we come to a quite complicated part, because we ask you about the preoperative localization of the target lymph node. If you have not marked a target lymph node before neoadjuvant chemotherapy, you don't have to answer this, because of course, obviously you don't have a target lymph node. There are very different methods of localizing and marking target lymph nodes that are used internationally. So this is why we had to include all these options. Some of the most popular ones are, for example, using a clip before neoadjuvant chemotherapy and then localizing the clip with a wire, for example. In the AXSANA study, we try to stick to these two definitions that you can see on the right side. Marking is something that we do before neoadjuvant chemotherapy. This means we are placing a marker inside a lymph node, and localization is a specific search for the target lymph node that can be performed either preoperatively, before start of surgery, or intraoperatively. Steffi, next one. And something that is very important to us, we would also like to know, if you have not performed preoperative localization, why you have not performed it. Because in the studies that have been published on targeted axillary dissection so far, we have seen that there are always some patients that do not receive targeted axillary dissection. But we don't really know, did the patients did not receive this procedure because, for example, the clip was not visible upon ultrasound, which is clinically highly relevant to us, or maybe the patient decided chose axillary lymph node dissection, or maybe TAD was not planned from the beginning. So this is why there is this specific question in case you have not performed preoperative localization. And for all of you that use, for example, magnetic seeds, radar markers, or radiofrequency-based markers, of course, we know that you do not need a specific preoperative localization, because you will be looking for the marker using a special probe intraoperatively. And here comes the question about the intraoperative localization of the target node. And as you can see, you have many options here. For example, intraoperative ultrasound, if you have used it to look, for example, for the clip or for a coil. If you are using a magnetic marker, you will be using a magnetic probe to look for the marker. And similarly, radar marker will need a radar probe. So there are several different options. Very importantly, we have included gamma probe only for the study sites that use radioactive seeds that are placed into the lymph node before neoadjuvant chemotherapy. This is something that, for example, we do not do in Germany, but which is quite popular in Holland, for example, in the Netherlands. So if you are looking for the sentinel node using a gamma probe, please do not choose gamma probe here, because gamma probe should be chosen here only by the study sites who use gamma probe to look specifically for the target lymph node that has been marked with a radioactive seed before neoadjuvant chemotherapy. And here are some very common combinations, like placing a clip, for example, into the target lymph node before neoadjuvant chemotherapy will usually result in using a wire guidance preoperatively or intraoperative ultrasound. And likewise, magnetic markers, radar markers will usually require a special probe. And something that is very interesting to, I think, all of us is the question what we should do in case we cannot find the marker. It happens from time to time, as you probably already know by now, that you perform targeted axillary dissection, you can't find the marker. Then you perform axillary lymph node dissection, and you can't find the marker. And there's no consensus worldwide what we should do with these patients. So of course, you should do whatever you would choose to do in the clinical routine in your hospital, but please document everything, because this would be very, very interesting to us to analyze later. And here is a small example of a study site from Germany that has been recruiting for quite a while right now. They have placed a clip into the target lymph node before neoadjuvant chemotherapy. And then on the day of surgery, morning of the surgery, they have localized this clip with a wire. So preoperative localization has been performed, yes, using wire, using ultrasound guidance. Steffi, if you could click me through the ultrasound guidance. And then we, of course, ask if the localization was successful or not. And we all know these cases where we look for the clip and we're not 100% sure that this is the clip, what we see, but we would localize with the wire nonetheless, and then see what happens during the surgery. So in this case, you should, of course, choose questionable and not successful. In this case, it was successful, and the study site does not use intraoperative ultrasound, so there was no specific step for localization search during the surgery because they have already placed the wire preoperatively. So I hope this is quite logical. And then comes a quite complicated table that will be the most important part of our analysis, our statistical analysis in the AXSANA. And to complete this table correctly, it is very important to think or keep in mind the study requirements during the surgery. So I have brought you a small example here. This is a patient who has received a clip into the target lymph node before neoadjuvant chemotherapy, and the surgeon decided to perform targeted axillary dissection after neoadjuvant chemotherapy. They removed 2 sentinel lymph nodes. One of them had a clip inside. So this is the first vial that goes to the pathology. As you can see, there is a lymph node, and this is sentinel lymph node, and at the same time, this is a target lymph node. The second lymph node, the second sentinel lymph node, did not obviously have a clip because there has been just one clip placed before neoadjuvant chemotherapy. So in the second vial, we have one lymph node, which is sentinel lymph node and non-target lymph node. And then the surgeons decided to remove 2 more lymph nodes during the surgery. They were not sentinel nodes, they were not target nodes, but they were somehow suspicious, so they decided to remove them. And these 2 lymph nodes go into the third vial. And this is very important to send these lymph nodes in 3 separate vials, because if you don't do this, you will just receive a report from your pathologist saying 4 nodes, one of them has a macrometastasis, but you will not be able to say which one of them was macrometastatic. Next slide, please. And in this case, the first question when you will be completing this table online will be, has there been a lymph node that was at the same time sentinel lymph node and target lymph node? Yes, in this case, we had 1 such lymph node. And then you can complete everything in the table. There was this sentinel target lymph node had a macrometastasis. Then we had 1 sentinel non-target lymph node that was tumor-free. And then we removed 2 more lymph nodes that were non-sentinel, non-target, and they were tumor-free. So this is very important to think or keep in mind that the patient is participating in the AXSANA during the surgery, and we would recommend you to speak with your pathologist so that he or she knows that you require specific report for each vial. And then comes a short CRF concerning planned adjuvant therapy, and you will be also asked whether there have been any complications after the surgery in the axilla. And the patient goes to follow up, which will be conducted yearly during year 1 and throughout year 5. And after year 1, 3, and 5, you will have a short reminder to give the patient the quality of life questionnaires. Because as you know, the quality of life and arm mobility is a very important primary endpoint of the AXSANA study. So the patient fills out 4 questionnaires, and there are also 3 additional questions concerning smoking habits and physical activity. So those of you who have already started recruitment know that you give a patient a package of quality of life questionnaires. This is just 1 file that you have to print out. And in this file, there are already 4 questionnaires plus the additional questions. And the patient is required to answer all the questions at baseline, which is before surgery, within 4 weeks before surgery, and then after year 1, 3, and 5. And the questions are identical at all these time points. We have planned that each country will have the possibility to give the patient questionnaires online, which is very, very easy, which means that you only have to print out a link that is patient specific, give this link with the password to the patient. It's just one page that you have to print out, and then the patient can log in herself, and she can fill in the questionnaires online, which is very easy for you as a study site. Right now, we have started this online platform for Germany and for Sweden. So we are hoping that this will work out fine, and we will inform you as soon as your country is able to participate in the online quality of life questionnaire platform. During this time, as long as you are not participating in the online platform, so as long as you're not based in Germany or Sweden, please give the patient the quality of life questionnaires that you have printed out. Then you have to collect them from the patient and send them as a scan directly to us. The email address you can see below. This is axsana@youbreast.com. And here I have included, Steffi? The picture of our coordinator from Karolinska from Sweden. This is Matilda Appelgren, that most of you probably know by now. She's based in Stockholm, and she's coordinating the whole quality of life analysis. So you have probably emailed with her before already. And just that you can, who is this our organizing committee. Professor Kuhn is chair of EU Breast and also chair of the AXSANA study. Dr. Steffi Hartmann is based in Rostock, and she's actually PI of the top recruiter right now. And you can always write to us if you have any questions. Thank you very much.
Okay, thank you very much, Maggie, for this excellent presentation of our ECF and the documentation system. So may I ask if there are any questions from the participants?
I see no questions in the chat.
Yeah, me too. So maybe one comment. You pointed out nicely. So I think what you can see that you are entirely free in the technique you're using. So for example, for the sentinel node biopsy procedure alone, and there are some countries who really do the sentinel node biopsy alone, like Italy. So we do not require to take out 2 or 3 sentinel lymph nodes to have a combined tracer technique. You just do what you usually do. And this allows us to compare the different techniques. Maybe I can comment on one question, and I think Lucas from the Czech Republic is in the audience. Lucas, you asked today, and this is a very important question, when can I include patients? And I think this is important for all those of you who start the accruement right now. So although we recommend to start the documentation at the time of diagnosis, you can still include patients at the time of surgery. So if you have patients under neoadjuvant chemotherapy and they fulfill the inclusion criteria and you have the data available, you can still include these patients. And this will allow you to include many patients at a time when you are starting your recruitment. So I see there are 2 questions from the chat.
Yes, there's a question from Gita. Hello to India. I'm not sure what time it is, but it's probably in the late evening where you are. So Gita, you have asked how the patients who are receiving breast conserving surgery with some kind of oncoplastic procedure, how they should be documented. We will not exclude these patients from the analysis because it's quite difficult to say which oncoplastic procedure is the large one or a long one. So we decided to include all patients receiving breast conserving therapy in this duration of surgery analysis. We will only exclude patients receiving reconstructive surgery with a flap or an implant.
Right. Thank you, Maggie.
Okay, there's one more. Okay, that twice. Thank you. Thank you very much. So I'm very happy we have been up to 45 participants, and so we are really happy that the idea that we have with our UBreast group to conduct international joint research on surgical issues. I think this is an excellent example. And maybe there are two more issues I want to raise. First one is we will circulate our second international newsletter early in May. So please include all your patients that you have, and these will appear on the newsletter. We have planned a meeting of the International Steering Board end of May or June. And as I said, it's important that we all work together as a big family. So we have representatives of every country in this International Steering Board. And we have planned a meeting in end of May or early June. And maybe one more issue from our side of UBreast. We circulated recently a survey on surgical standard after neoadjuvant chemotherapy. This was a project that was launched by Maria Gaspari from Switzerland in cooperation with some members of UBreast and from ESTRO, because the regional treatment after neoadjuvant is certainly an interdisciplinary issue. And I would be very happy if many of you fill out this questionnaire and also forward it to your radiation oncologists. And you can find the survey on our website, ubreast.com. And I would be very happy if we had many participants, and even if you could forward it to your national associations. So I see one more chat.
Yes, we have a question from Azerbaijan. Hi, Hagitat. So you have asked if you could include patients who have started chemotherapy in January. Yes, of course, as long as the patient has not received surgery, you can include them until the day of surgery.
Thank you.
I think one precondition is that we will have the ethical approval, and that we will have the contracts and so on. There are some formalities, and then you will get the access to the database, to the red cap. But I think we are on a very good way for you. Okay. So I see no further questions. So if there's anything that you want to ask, or any questions that there's one more. Can we include patients? It's from Gianna. Can we include patients just operated if we have all the data who have operated?
No.
No, unfortunately not. So if the patient has been operated, so the cutoff for inclusion of the patient is the time of operation, but prior to the operation. And it's at this time that the life quality questionnaire should be filled out. So unfortunately, if the patient has already been operated, so she cannot be included into the AXSANA. If she's undergoing chemotherapy prior to operation, yes, she can be included. Okay, so if there are any further questions, do not hesitate to contact Maggie or Steffi or me. So we are very happy to have all of you on board, and hopefully we can make this study a very big success. Thank you very, very much for attending. Okay, bye-bye.
Bye-bye.
Thank you. Bye.
Bye.